So they just started with the basic sack lunches, hygiene kits, socks, just, hey, here's something. You don't need to talk to me, you can just take the gift and walk away. Over time, that opens up doors, but you have to shut the clock off in your head long enough to listen, because sometimes they'll grab the hand away and walk away, and as you're jumping in the car, you see them wander back around in a big loop, and then you need to shut the car off and get back out, because they're going to tell you a little bit of a story, and they're going to start to trust you a little bit. From that comes all the goodness, all the amazing changes that happen. On the most profound fronts, that's getting people housing, it's getting them into detox, it's getting them the health care they need, into primary care, it's keeping them out of the ER when we can treat them with basic antibiotics, it's getting them to the ER when they are in a life-threatening issue where we're worried about sepsis and infection and clotting issues and stuff like that. So those are the big ticket items, right? Those are the things we're like, we know we're doing something good because, oh my gosh, something happened. But because people, when they live on the street, and whether there's a substance abuse issue or a mental health issue or both, or many other issues, many other little things that led up to them being homeless, they lose contact with their social networks. They get cross with their family and friends, they lose contact, they lose the cell phones and the computer access that allows them to keep on Facebook and social media. They lose those abilities and those connections, and you lose your social trust in the system, you lose your social skills, and as we start to re-engage and meet folks where they are, they start to gain those back, they gain a little more confidence in the system. When we take somebody to the ER, depending on if they are in that mental state of distrust, some folks will wait until they are absolutely on death's door before going into the system, because they've had so many bad experiences. They've been overlooked, they've been minimized, their issues, they've been just kicked right back out, and the time and effort that they've put into seeking medical care has not bore any fruit, so they're like, why would I do it again? And when they are in that mindset, we actually have one of our employees sit with them in the ER and wait for them to get through triage and wait for them to go, even going as far as waiting until they get a room upstairs. Because even though that takes, as everyone knows, 6 or more hours to get a room, it allows them to start trusting the system that they have just entered. And then they also know they can call us at any point, and we will advocate for them if they feel like they're not getting what they need. So we have a cell phone we carry on the van, and we give it out to everybody. They give us text messages and cell phone calls. They can say, I don't have a phone, I borrowed someone's phone, but I'll be on the corner of State and Lake at this time. Can you try to meet me there with a size 11 boot? We'll do our best to do that. But we're juggling a lot of balls.
Just a little question. These people, I assume they have no insurance?
It's a total combination. We don't know. Some of them have Medicare, Medicaid.
If you go to a hospital and you've got someone that, basically isn't insured, how does the hospital treat them?
The ER has to treat them. That's the safety net of the system, is that they absolutely have to.
At any hospital?
Every ER cannot turn people away. Having said that, they don't have to necessarily give adequate care. They do have to give care. And sometimes that question of insurance or housing status plays into the treatment, unfortunately. So,
do people stay with them because they get a desperate, different treatment there than other people would? Or are you pretty much treated the same?
Some ERs and some doctors are different, right? And some nurses. It's just a little bit of a crapshoot. Now, some institutions do much better historically with our homeless population. And that is partially because all of the major medical institutions with medical schools have started some form of street medicine program. In doing that, they've realized that it is a huge need. This population has a totally different set of needs. They have the needs that everyone else has, the physical, medical needs, but they have so many social determinants of health outcomes around that if those things aren't also addressed, you're wasting your money. Because this is a very real thing that happens. People will come in, they wait till that last minute. They have sepsis from an infection or endocarditis from an infection. They have, so major heart issues, major life-threatening issues. They pump $60,000 in care into these folks over the course of a couple weeks, kick them right back out to the street. What's going to happen. They're going to get sick again, they're going to come back weaker, and eventually they're going to die, and all that time, money, and energy has gonna be resulted in not a longer life, not a higher quality of life. It's just the cycle of diminishing returns until they pass away. So.
Is the problem of homelessness the big factor here?
Oh, yeah, because if you're living under lower whacker, you can't make your follow-up appointments are very hard to get to. There's a lot more ways you can get reinfected. You're not protected against the elements, so your immune system is compromised right off the bat. I mean, add violence, you add car wrecks and person-on-person violence on top of all of these considerations. You can see how it's much more complicated than if I go to the hospital or doctor, I get care. They know I'm gonna go home to a house, a spouse that'll take care of me, I can get to the hospital. These folks have all these complications, right? And what if they don't have a cell phone? They can't even tell the time of day. I mean, how are they supposed to make it back reliably? So part of our job is working with all these major institutions to promote the growth of their street med teams. Those doctors, medical students, and residents ride along with us. They learn how we do things, they take it back, and they make it their own. And in doing that, they're starting to change the processes through the hospital system itself. For one, documenting whether someone's homeless on admit to the ER. If they're starting to do this, it's not in every hospital yet, but as they do that, that triggers a social work referral, which means if they're gonna spend time in the hospital, that social worker can help them get an ID. I mean, with no ID, you get nothing. Are you on Medicare or Medicaid? If not, let's get you on Medicare, Medicaid, which then opens up more resources, right? So as they're spending the time in the hospital, that's being useful on from a social work standpoint. And when they get discharged, they go ahead and contact us, in a perfect world, to say, this is where we are at with our social worker. Then our social worker would pick that ball up and keep running with it. Are they on the housing list? Do they want to get into detox and rehab? Do they have a psychiatrist right down the road? What are the follow-ups? Then the clinical folks would call us and say, they have a follow-up with wound care on this time and at this date, and this is how you should be caring for the wound while you're out there, and we can bring those materials out and help take care of the person out on the street until that point. So there's a lot of other large picture ideas where we're trying to get movement on a regional level to get respite beds available, which is so when people spend 3 weeks in the hospital and have a lot of care invested in them, they then have a month at basically a shelter with an RN staffed on board, so they can get that follow-up care. They can get their psych meds tweaked in so that they're stable and can manage their own requirements, right, for follow-up. So they can work on housing further, so they can stay healthy and build up their immune system before they go back out. And you know, in other cities who have done this, the return on investment are amazing. So this is one of those like no-brainer things where the economics and the more what I would consider the morality of the situation and what my goal as a provider, medical provider, they all line up. They're all heading in the same, some of these things. They all say, do this because it works for all fronts. So those are some of the other things we're working on. So we're trying to meet, 4 days a week I'm out trying to work with individuals. 1 day a week I'm in the office trying to do all this other stuff and trying to work on networking, trying to work on not duplicating services offered. So if there's other outreach people doing the job, then we just say, hey, come along, ride with us, or let's plan, how do we get our folks into your stuff? And so as part of that, Haymarket is a detox and rehab center, substance abuse center that's got a long, rich history in Chicago with big treatment facilities. They have a 24-hour, 7-day-a-week office open at O'Hare, and they look for folks who spend the night there or come in on the blue line to help. And now we go out there twice a month with our medical bags and try and provide medical care to their folks. So it's that same kind of thing of trying to connect the dots for our folks. But I wish I had the pictures because it really brings out some of the stuff. Some of the times we're underneath bridges. Some of the times we're walking up through a break in the fence up by the railroad tracks. We'll obviously downtown, everyone's seen folks panhandling anytime we call it bagging. If they're bagging, we stop off and offer them lunch and ask them if they need help. And so we, as the van, which is what we call street medicine, we don't have a given route, but we're all over the city and we make sure we hit certain places, but we're just kind of freelance. We go where we're needed. The big RV has a very set schedule. It goes to the same 4 communities twice a week. And so they know when and where to expect those providers to be there, and we can refer our folks from the street to those as well. So we try to hit it on both fronts, where we have the stability of a mobile clinic, and we also have people with absolutely no agenda. So, yeah.